In this video we will discuss primary hyperaldosteronism or Conn syndrome. Most common cause includes solitary adrenal adenoma, accounting for 80 to 90%. Bilateral adrenal hyperplasia is the second most common cause. Primary hyperaldosteronism can present without any symptom. Other features include hypertension, hypokalemia and metabolic alkalosis. Primary aldosteronism is the most common form of secondary hypertension. Approximately 30% of with primary aldosteronism are hypokalemic. First step is to obtain biochemical diagnosis. Plasma renin activity and aldosterone levels are done to obtain aldosterone to renin ratio. A high aldosterone to renin ratio is suggestive of primary hyperaldosteronism. Next step is to undertake saline suppression test or oral sodium loading test. Lack of suppression of aldosterone levels indicates primary hyperaldosteronism. Next steps include imaging of adrenal gland. Either CT or MRI adrenal is undertaken to assess adrenal gland. Next step is to confirm if unilateral or bilateral gland is involved by undertaking adrenal venous sampling for aldosterone or 11C-metomidate PET scan or both. If there is unilateral disease, then surgical excision is preferred treatment option. If there is bilateral disease, like bilateral adrenal hyperplasia, then medical management is undertaken. Spironolactone is the first line, followed by eplerenone or amiloride. Primary aldosteronism should be excluded in patients with hypertension with spontaneous or diuretic-induced hypokalemia. Furthermore, primary hyperaldosteronism should be excluded in following patients with normal potassium: patients with severe hypertension, drug-resistant hypertension, hypertension with adrenal incidentalloma, hypertension with sleep apnea, hypertension and a family history of early-onset hypertension or cerebrovascular accident at a young age. All hypertensive first-degree relatives of patients with primary aldosteronism